My name's Esmond. Slightly different background coming into healthcare. I'm an engineer by trade and computer scientist. I've worked in the defence space and aerospace industries, predominantly looking at manufacturing, engineering, quality, acceptance. So really high-end, high complexity, high value items, jet engines, rocket boosters for Ariane and such like. And somehow I ended up in healthcare, and truthfully I absolutely love it. I think it's the challenge is immense. There are so many possibilities, definitely for data, and I think oddly in some ways I lack the clinical understanding and knowledge that comes over decades of working in such subjects. But looking at data, you can focus on these things conceptually, and quite often not, regardless of the context. Some of the things that apply are incredibly similar. Okay, so the CocoNet project, right in the midst of COVID-2, I started managing a work package within this project, and it was looking at COVID data, a recording of and transmitting of, and from laboratories around the UK to report on the status of COVID. So as you can see, I last did this presentation a good year or so ago when we literally just finished the work, and funnily COVID cases were rising then, and obviously quite a good website, Our World in Data. It's quite interesting. And a couple of days ago, I thought, I'll just, obviously COVID's not around anymore, isn't it? How wrong can one be? We all know that this will continue mutating and potentially be a problem in the future. And even to this day, this was from a few days ago, there are still cases and there are still deaths from this virus. So it is still around and ever evolving, as I'm sure you all know. So the CocoNet project started, was given the green light. I think it was April, literally 3 or 4 weeks into the COVID pandemic. It started October 2022, and it was looking at trying to develop a research platform for researchers to find and access data around COVID. So develop the infrastructure, ensure it's trustworthy, secure, etc. By way of that, look to answer key questions around COVID, and I was involved with much of it. But the actual work package I looked at was trying to understand how to standardize antibody data. So nationally at that point, no standardized capture for serology data. Without full understanding of what's happening within communities, how can you make informed public decisions? So therefore you need better quality data, more of it to better inform decision making and make the right choices. At the start of the project, it was thought that all these labs were collecting said data, that obviously they were doing a fantastic job, as all these people were and still do to this day. But lots of different perturbations in the pipeline, as it were, and I'll get into those shortly. The partners, so we had National Pathology Exchange, so they collect all laboratory data that's been recorded and transmitted to them, and then that's sent on to NHS Digital, and then collated and sent to MS and or the government for reporting. We had Barts, so we had the labs at Barts, we had Great Ormond Street, the labs, and then we got talking to NHS Tayside by way of Emily, and they got involved as well, which was fantastic. So we had 3 pilot laboratories. We had the national organisation that collated and sent on this data. So it was seemingly a good setup. So what is the problem? Well, You have test kits, you have analyzers, you have LIMS, so that's laboratory information management systems. It's the piece of software that collects the data. And then all through these stages, you have data that's produced, collated, sent on by way of trust to MPEX and then to NHS Digital. And what you find is the test kits and the reagents, there are standards around these, and it's quite widely reported within literature that there is variability in these. But me with my engineering background and looking at these from a manufacturing perspective, different context, same principles apply. There is variation in analyzers, and there is variation in LIMS systems. And what you often find is, through looking at this over a period of a couple of years, you find that the same analyzer can be set up in a different way, and you find a laboratory information system, the same piece of software, again, can be configured differently, thereby producing variability in the results. So that not only happens here with test kits, the reagents, you then have another source of perturbation, so the analyzers, and then the LIMS system themselves. So effectively, you could have 4 sources of variability. And if there's no standardized way of capturing these things, you then add another set of variation to this process. So the focus was develop a minimum data standard for COVID serology. So bounding it quite tightly, and where that sat in terms of the process, so test kit, analyzer, and really here, trying to figure out what's the minimum aspects you should be kept in data attributes, then fed into the LIMS system and then reported onto MPEX and then NHS Digital. Method, I've pulled this out of the journal paper, obviously collect data attributes. I won't spend too long on this. Assess the data attributes. Effectively, it's a closed iterative system loop. So find out what you have, assess it, feedback, see what other people are doing nationally, internationally, policies, standards, literature, feedback, change those attributes, and obviously assess and decide what should be in the minimum standard and what shouldn't be. And that was done by way of people from both within the work package, and I'll list those contributors at the end, but also within the whole Coconut project and latterly NHS Digital. So it was round robin process. We'd vote on things. So it was brought about by consensus and using something called mini Delphi technique. So voting to decide what should stay and what should go and such like. Where did all the influences come from? We initially took, I think, 36 data attributes from partners within CoConnect. So literally, what do you record, asking all the individual organizations and laboratories. We looked at what the pilot laboratories were recording. I went away and looked at the work from Bristol University. So they're quite widely used serology questionnaire. I got involved working with a little bit at the University of Calgary and their Sera tracker. So they developed a piece of software that looks at all the different publications around the world, particularly focused on COVID. So that was a fantastic source, not only in terms of software, but also talking to the researchers there. Then again, feedback from all the people within the project. Again, interactions with NHS Digital, interactions with the Pathology Unified Test List, which was an absolute key piece. And specifically look at what was going on in the States, so the CDC, looking at how their take was on it. And I think they came up with the minimum set of attributes, I think about 20. I'll get into that shortly. And obviously what was going on with the World Health Organization. So here we go, two anonymized and somewhat simplified examples. I'm sure you can understand why. So from the pilot NHS labs, and as you can see here, we have some aspects around what's being tested, IgM, IgG. Is it detected? What's the optical density? So the actual result. I'll get into this shortly to show you the standard. Any clinical comments? Obviously, that's key. And you can see there are, straight away, between the two different lab feeds, there are a lot of similarities. So we've got qualitative, we've got quantitative, so signals, cutoff ratios being reported, which is a key aspect of this. And quite funnily, one of the, which I thought very interesting, one of the labs had actually standardized their free text. So they'd actually developed a drop-down menu, which I thought was fantastic. And you can see here they started to record the machine names and such like. So what we derived from all of this, some quite intense work, all of us stuck at home, shielding from COVID and such like. I must say a lot of effort was put in by the laboratories, the people within them. I'm sure you understand that. Trying to do the day-to-day job, testing all these PCR samples, etc., and then being asked by me politely in Teams and emails and such like, could you send us what you're doing? So they went out of their way to help. And what we've derived is 12 data attributes. So I'll just quickly run through them. I grouped them here. So we've got identifier, obviously. We've got the test setup, so the input, and then we've got the output, the results. So we've got an identifier, date and time of test, obviously. The test code, so which test is being performed, sample code, serum or plasma, the analyzer type. Now, I'll get into this in detail in a bit. So which machine's being used, test kit name, which assay, the outcome code, did the machine pass or fail for the test, and then the results. So broken down into qualitative, quantitative, and then obviously some free text comments, because these can be key, capturing feedback from the laboratory's perspective. Went away and did some feasibility studies. So we developed that minimum data standard, I think about a year and a bit in, after a lot of work. And it's all very, oh, I've got a brand new standard, fantastic. Is it fit for purpose? Does it work? Does it represent what laboratories report and produce and then pass on to the relevant organizations? So took that data standard, we did some feasibility tests with the laboratories, and this is what I found. Some in the green, are these things present? Are they in a good enough condition to be standardized? Where it's green, absolutely perfect. It's date and time of test, you identify NHS number or CHI number, Scotland. Test outcome, qualitative results, so positive or negative or indeterminate, so text-based, that's fine. Quantitative results, that's fine, numerical value, optical density. Then we have some aspects here, so the amber, so they're capturing things, but they're using what we would term locally coded naming conventions, something that's natural as humans do. Ask 20 people in the room to save a Word document, please name it. I don't know, something about data standards, and I can 9 times out of 10 say 20 people will come up with 20 different names for the Word document. Same applies here. So they're there or thereabouts, but these are not recognized international standardized terminologies they're using. So there was some bit of scope for work there. And then things in red didn't exist within the message structures. Interestingly, what we found, a lot of these laboratories are actually capturing this data, but there was sometimes, because of antiquated systems, they had no way of feeding it into the message that they would report on, or they were not being asked to report it. So we thought it wasn't quite often not being captured. That was quite the contrary. These labs were capturing it. They just had no way of passing it on which then we did look at in terms of trying to build a potential for building a data pipeline into an NHS Digital for this at the time. So what did come out of this? Well, we were able to develop some standardized vocabulary. What I've found is, with my standards-based background, ontological perspective, is that these locally encoded ways of naming a machine, it's all very well saying it's an Abbott, but which Abbott? Is it an Architect C16000 here, for an example, or is it an Architect Selden Emerald 22? If you want to be able to determine potential variance between machines, surely it's needed that you precisely name and state which machine it is. So what I've developed, I think it's 231 different concepts for machines. There will be more, but we've been able to develop the CoConnect standardized laboratory. Sadly, there are no standard SNOMED codes to map this to, so there's a big hole in SNOMED. So there's potential work to do there. But it would be fantastic if we get to a point where a laboratory could specifically define the machine they're using. And then again, we have the laboratory information systems, management systems, named many of those as well. And as part of the wider CoConnect vocabulary, we defined and standardized terminology for serology measurements as well, to try to fill in the gaps that existed and work towards a wide-ranging and standardized view of reporting laboratory data. Again, this is live in Athena currently. This was as of August, which is fantastic to get this up by way of the Odyssey community. And this exists now. Feel free to browse. So in terms of outputs, what do we have? We've got a minimum data standard, 12 data attributes, and we have checked that with pathology standards within the NHS Digital and the Royal College pathology team. We've developed by engaging IQVIA to help us develop a standardized CoConnect vocabulary, and it's much wider than what I've just shown you. We ran some feasibility studies to understand what could be achieved and what couldn't be achieved in terms of applying that data standard to their reporting processes. Very happy to say they saw very few problems in terms of implementing the data standard. Okay, time and effort, but no large hindrances in terms of applying it to their machines and systems. We went a bit further. We looked at the actual LIMS suppliers. So I think we contacted 10 of the big LIMS suppliers. We got 3 replies back. Obviously, it took a lot of time and effort just to get that far. What we found is 2 of them, they actually came back and confirmed that they were actually capturing and reporting these things at that very moment in time. So they actually saw very few problems in setting this up and on their systems to be able to record and then report. However, one did state they often set up their systems independently. So it might be the same bit of software, but they would be configured differently for a number of given labs. So couldn't say with concrete response whether it will be easy to implement or simple to implement. So there's definitely some further work to look at, not just those LIMS suppliers, but further afield in terms of implementation. We did look at potential to build a data pipeline into an NHS Digital. So there's a report on that. And then a conference paper, journal paper at the moment that's in with the Annals of Clinical Biochemistry. It's with the reviewer for the reply comments, so fingers crossed. It's been accepted, but pending changes, so fingers crossed on that. And then finally, all this work has fed into Kathy Sadlow review with HDR around data and national work on that scale. Where do we go? Minimum data standard, it's ready to go. It's been, we've tested it with 3 pilot NHS laboratories, LIM suppliers, but I'm sure some of you know lots of different systems in different laboratories, so there will be effort needed to understand who's doing what where with what, to gain the greater picture and then understand how you progress from there. Key aspects of this, I would say, the reporting of signal to cutoff ratio to understand levels of virus within a per capita for a given area within the country. Like I said, quite often you find the laboratories and systems are capturing it, they're just not reporting it. And then obviously, if you want to look at variability to understand the quality of the data that's coming out and whether you can trust it or not, then look at actual naming and reporting of those. And here we go. So Emily Jefferson up at Dundee, Phil Conn Nottingham, and then we had Joan Martin at Barts, Neil Spear at Gosh, Andy Harris over at MPEX, and then Michael Ferguson, Dundee, and then Anthony Eram, Jenny, and myself and David work within CoConnect. Any questions? Am I about on time, give or take?